Welcome, everybody. My name is Jerry Brock, and I'm the current president of the International Society for Sexual Medicine. It is an absolute pleasure to be part of this very important webinar looking at vaginismus. And I know that we have a huge number of people that are signed up and registered for this event. I can't imagine that it will be anything but an absolute huge success. We at ISSM are looking forward to starting, getting ready for our upcoming meeting in Dubai, which would be a world meeting with MESSM as well as ISSM. And so I'd like to just make the point that at ISSM, we are the most credible source of information related to sexual medicine, and that it is an absolute vision of our society that every human has the right to a healthy and satisfying sexual life. We have been around now for more than 45 years, and the idea is that we provide a platform for everybody to learn about sexual medicine through our webinars, through our video journal, through our print journals, through important meetings that happen on a regular basis, both from our regional affiliates as well as our world meeting, as will be happening in mid-December in Dubai. Next slide. So the ISSM really is an international society that has affiliate groups across the world, really in all continents except Antarctica. We are able to transmit our information through the series of publications that we have, the Journal of Sexual Medicine, which provides a platform for original research and up-to-date systematic reviews, Sexual Medicine Reviews, and Sexual Medicine Open Access, which provide, again, really important information to healthcare professionals around the world. And our new video journal, which would be the Video Journal of Sexual Medicine, which will have both prosthetic urology and other forms of protocols and techniques for sexual medicine. Next slide, please. So with that, I'm going to pass it along to Dr. Vagali, who will tell you about MESSM and tell you about the very exciting news of our upcoming meeting in Dubai in mid-December, as you see here. Dr. Vagali.
Hello, thank you, Gerald. Thank you so much for this great collaboration with ISSM. I would like to thank you as president of MESSM. I want to thank all the ISSM board members and previous president Anna Maria, and you as president of the ISSM for this great collaboration, for this great webinar. As you know, we invite you to attend our world meeting on sexual medicine, which will be in Dubai from December 15 to December 17. And please don't miss the previous day of the meeting. On December 14, we will have some workshop for female and male sexual dysfunction. So don't miss even December 14. We are planning very nice scientific program with our chairs. And we are planning also very nice social activities. So it's an opportunity for everyone to come with family, to have a nice meeting and to enjoy Dubai in the warm weather and during the holidays. So please come to our meeting. You will benefit from many benefits. One of them is you can apply to the grant to attend this meeting. You will have the opportunity also with the support of ISSM to present for membership, dual membership, ISM and MESSM dual membership, and you will get an additional 1 year free membership. So you are welcome to attend the world meeting on sexual medicine. I hope we can play the video. So hope to see you in Dubai for the World Meeting on Sexual Medicine. As MESSM Society, we were founded in 2010. We were affiliated with ISSM in 2012. We encourage the highest standard of practice, education, and research in the field of human sexuality. We work on to develop scientific methods for the diagnosis, prevention, and treatment of conditions affecting human sexual function. And we promote the publication of medical and scientific literature in the field of sexual function. We have different members from the different countries in Middle East and different affiliated societies. Next. And we invite you to be a member for dual membership, MESSM, ISSM, and it's free for students, for doctors in training, for residents. So please join our membership program. For the dual membership, you will have opportunity to have link to the different ISSM university and all the Journal of Sexual Medicine. And so you can also present and be active in our society. Next. And I invite you also to follow our newsletter, the MESSM newsletter, which includes a summary of the best abstract in the field of sexual medicine. And again, I invite you to look to our website and the new website platform. You will have direct access to ISSM University, to the Journal of Sexual Medicine, to all the video prosthetic urology, to the newsletter, to the social media activity and infographics, and to a site on Arabic for all the Middle East members and like people who are willing to follow the different news on sexual medicine. And now I will take the opportunity to present two of our great colleagues, our Professor Anna Maria Giraldi, former president for ISSM, and she's the co-chair for the scientific committee for the World Meeting on Sexual Medicine. She is a professor in the University of Copenhagen in Denmark. And I'm so glad to present her because, and also she's very active. She has published more than 100 papers. She's always active and always supporting the activity of Vaginismus Masterclass, like we are having now a webinar. And our second moderator is Dr. Myriam Mahbouli. She is the president of the Société Tunisienne de Sexologie Clinique. She is a teacher at the University of Thhis in Tunis. She is an active member on the scientific committee of the World Meeting on Sexual Medicine and MESSM committee. So please welcome Dr. Myriam Mahbouli. It's for you to present. Thank you.
Thank you, Dr. Ferrali. It's a real pleasure and a great honor to be here today with you and to moderate with Professor Anna Maria Giraldi. We will start with the lecture of Dr. Rana Khaled. She is medical doctor with a PhD in clinical sexology. She will talk to us about epidemiological and etiological aspects of vaginismus. Dr. Rana, you have the floor.
Yeah, hi. Yeah, hi. Hi, everyone. And,
can I just, before you start, Dr. Rana, I'm sorry, but just for you who listen, welcome to everyone. It's such a pleasure to be here. We have a very highly esteemed faculty. We take the questions and answers after all the presentations. So please, if you have questions, go to the Q&A in the bottom, write your question, and please address it to the speaker you want to ask the question for. So in the end, we will have a discussion and question to all the speakers. And if you find that it's a little bit difficult with English, you can go to the show caption in the end too, and there will be translation to other languages. So that might help if you are not so comfortable with English. So sorry, doctor. So now the floor is yours. Thank you.
Okay. Thank you so much. And first of all, I'm honored to be here with you today to speak about an important and unique topic, the vaginismus, understanding the epidemiology and causes for vaginismus. First of all, there's no conflict of interest, nothing to declare here. Vaginismus, based on the DSM-5, it's a part of genitopelvic pain penetration disorder. Sexual pain disorder, here it's indicating a persistent or recurring difficulty in allowing vaginal entry of the penis, finger, or any object, despite a woman's expressed wishes to do so. Vaginismus often include phobic avoidance also and anticipation of intercourse, fear of experience a pain along with variable involuntary contraction of the pelvic musculature surrounding the outer 1/3 of the vagina. So which can make intercourse or vaginal examination or insertion of menstrual cup or tampon impossible or even painful. The epidemiology of vaginismus is not well understood. It's often underreported and underdiagnosed. We have to mention, first of all, that ethnicity and culture play a vital role in sexual complaint in terms of its presentation, its treatment, its etiology, its meaning, its help-seeking behavior, and treatment preferences. So that's why the epidemiology of vaginismus may vary across different population and cultural contexts. Further research is needed to better understand the prevalence, risk factor, impact of vaginismus to improve diagnosis, treatment, and support for affected individuals. Vaginismus can affect women at all ages, but it's most commonly reported in women of reproductive age, typically between 18 and 35 years old. Next, please. Okay. For the prevalence, we can say that one study reported that the prevalence of vaginismus was between 5% to 17% in clinical setting, but other study referred that the prevalence of vaginismus is in a systemic review to be between 0.4 and 8%. This variation may be due to differences in study population, diagnostic criteria, cultural factors also. Vaginismus is often underreported due to stigma and shame. Next, please. Treatment-seeking behavior. Many individuals with vaginismus do not seek professional help due to embarrassment, shame, lack of awareness about available treatment. This can contribute to the underestimation and its prevalence and impact. Next, please. Okay, we have risk factors. Risk factors that could be associated with increased risk of developing vaginismus. And those risk factors could include history of sexual abuse or trauma, negative sexual experiences, poor body image, culture or religious beliefs that stigmatize sex, anxiety or fear related to sex, relationship difficulties. Those are risk factors. Just to know that vaginismus can occur in women without any non-risk factors. Next, please. Okay. So the etiology of vaginismus and the underlying causes of the condition is not fully understood, as we mentioned before. However, several factors have been proposed to contribute to the development of vaginismus. Like any other, or like many, looking to many other sexual problems, it's important to approach the etiology of vaginismus from the biopsychosocial perspective, considering the interplay of biological, psychological, cultural, and social factors in it. Just to mention also that each individual experience with vaginismus may be unique, and comprehensive assessment is necessary to understand the specific factor contributing to their condition. The contributing factors for the etiology, please do the previous one. Okay, could be the psychological factor, the fears and anxiety, conditioning and learned response, physical factors. Next, please. Okay, I will start by the psychological factor. Psychological factor play a significant role in vaginismus, Like, let's say we can talk about a past traumatic experience such as sexual abuse or assault can lead to fear, anxiety, and conditioned response of muscle tension during attempted penetration. So even if the psychological factor, the negative attitude from childhood continue to affect the woman emotionally, even though as adult, they no longer hold them. Sexual assault abuse can lead to fear, anxiety, conditioned response of muscle tension during attempted penetration. We can see also from other factors, negative sexual experiences, cultural and religious belief that stigmatize sex, relationship difficulties. Next, please. The other factor is the fear and anxiety. In the fear and anxiety here, we can talk about that fear and anxiety related to sex, to penetration or pain can trigger the involuntary muscle spasm characteristic of vaginismus. So they're related to sex, to penetration, to pain, to performance, to body image. All of these factors can trigger also spasm. This fear may be rooted in cultural or societal messages, past experiences, personal belief about sex. Next, please. The physical factor. While we can say that psychological factors are considered primary in vaginismus, there may be some physical factors that contribute to that condition. This may include anatomical abnormalities, infection, hormonal imbalance, other medical conditions that can cause pain and discomfort during penetration, vulvodynia, vestibulodynia, vestibulitis. However, it's important to know that physical factors are less common and usually secondary to psychological factors in vaginismus cases. Next, please. Okay, the conditioned and learned response here. It's important here for the conditioned and learned response to know that vaginismus can be learned response to pain or discomfort during attempt penetration. If a person experiences pain or discomfort during their initial attempts at intercourse, they may develop a fear anticipation of pain leading to muscle tension and involuntary spasm. In some cases, previous please. In some cases, the exact of vaginismus may be unknown. Thank you so much.
Thank you so much, Dr. Khaled. A wonderful presentation, putting into the frame what is it that we are talking about when we talk about vaginismus. Thank you so much for sharing all your knowledge about that. Can I have the next slide, please? So now it's a pleasure to introduce to you Dr. Mona Rader, who is a holder of neuroscience, master degree, and a PhD in psychiatry. And she has spent more than 20 years in the field of mental health services. And she also has a private practice in Cairo. And she's very active in the academic field, in clinical supervision, and has a very broad experience in treating people with mental health problems and people with sexological problems. So it's so nice to have you here, Dr. Rader, and welcome.
Thank you. Thank you, ISSM and Middle East Society. It's my pleasure to share with you management from psychological, psychiatric, and sex therapist perspective. Next, please. I have no conflict of interest to declare. Next, please. When we talk about the management of vaginismus from the psychological, psychiatric, and sex therapist perspective, we have to put in mind the cycle that takes place. It's the perceived threat. Genital sexual pain disorders are complex, and it's recommended that their evaluation and treatment are performed through a comprehensive somatopsychological and multidisciplinary approach, as my colleague Rana has explained previously. With attention to the following areas: the experience of pain, the emotional and psychological profile of the client, any context of pain, past genital mutilation or sexual abuse, the genital mucosal membrane, the pelvic floor, sex and partner therapy. So So it's a comprehensive approach. Evidence support personality traits of catastrophizing pain cognitions and harm avoidance in women with lifelong vaginismus. Women in lifelong vaginismus group indicated significantly more causal beliefs related to expectations that the intercourse is painful, fear of injury, dislike of the idea of having a penis inside the vagina, fear of losing control, negative body and genital image, feeling disgusted when thinking of intercourse, and fear of intimacy when compared to acquired vaginismus group. And as you know, there are the primary and secondary. We all think of vaginismus in the very young age, but actually we do see some cases of vaginismus in multipara patients. She had a good sexual life and she has kids, but she developed a secondary vaginismus. Next, please. I remember this table. I have seen it the first time in 1997 when I attended the first sexual medicine school, and John Dean has presented this table, and it has always been in my mind when I see a vaginismus case, because there is a biological cause, physical, psychological, and social. There is a predisposing factors, precipitating and maintaining factors that we have to put in mind while we are profiling the case, making the case so that we can put a therapy. Next, please. For example, a patient with neurotic traits under the influence of the social impact or the media impact or knowledge she has gained during her adolescence. The precipitating factor is becoming married. She's fearing the anticipation on her psychological and phobic and catastrophizing the pain. So biologically, she develops anxiety symptoms. As much as the attempts to penetrate are continuing, the psychological impact here is increasing, and the family pressure, especially in the Middle Eastern society, is very high. That is a maintaining factor for her vaginismus to continue. Acknowledging these factors in mind will help a lot into designing the best treatment model for this patient. Next, please. Management plan, we start with history taking, and your options are very wide into using an already available medical sheet to ask the questions, but the rule of thumb is that you have to ask in open-ended questions and closed-ended questions. With open-ended questions, you get so many informations, you ensure the patient of the confidentiality and safety in your office. You need to do a sexual assessment. And when you do the sexual assessment, we need to go back to the development. If there has been any exposure to improper material of sexual exploitation, if there has been any sexual assault during childhood, if there has been any sexual knowledge that is incorrect. Psychiatric assessment is very important. Since I'm a psychiatrist, so I do psychiatric assessment using the SCID-1, which is the structured clinical interview based on DSM-5. As we do see these patients presented with anxiety disorders, sometimes depression, mild depression due to their problem. They don't usually seek medical help early. They keep trying to penetrate, but actually they present within a month, 2 or 3, sometimes up to 10 years. Following the psychiatric assessments, personality traits, state, and disorders using the SCID-2 assessment. Next, please. Interviewing the assessment of various dimensions of sexual functioning are important both for the patient and the clinician's perspective. Many times the patient complain about sexual dysfunction for which they are distressed. They may not be aware or knowledgeable many other aspects that may be affected adequate sexual functioning. Accordingly, a thorough evaluation of various aspects of sexual functioning can broaden the understanding of the problem for both the patient and the clinician. For instance, when a patient is subjected to the man, the partner, who's not doing a foreplay properly, she might get into a vaginismus. Interviewing the person in concrete with the biopsychosocial framework, the assessment of the client's complaint need to be multidisciplinary unless otherwise indicated. A good assessment rule of thumb is to conduct a comprehensive assessment for all clients, regardless of the presentation. Multidisciplinary approach should not delay starting the treatment, which is very important because usually we see those patients in a marked distress. I see a lot of them where they are about to get a divorce, the family is involved, the pressure is high, the tension is too high. So you need to start therapy and putting in mind the need for a multidisciplinary approach. You might need to send her for a gynecologist. I might need to send the man for an andrologist. Next, please. Basic screening, we have to legitimize and put the importance of the complaint by normalizing and universalize the conversation about sexual health issues. Start with statement that open-ended question, continue inquiry about sexual specific questions, follow up positive responses with open-ended invitations. Next, please. Sexual problem assessment, you need to know the nature of the problem exactly, phases of sexual response affected and pain, single or combined if there is a sequence, lifelong or acquired, generalized or gradual predisposing, precipitating and maintaining factors. Contouring factors, psychological, biological, impact of distress, exacerbating and alleviating factors, what increases and what decreases, the partner response and related issues. The partner plays a major role. Although it is a vaginismus, it is related to women, but the partner role is very important. Treatment, if there has been any before, because we see patients who have been taking any kind of medications or injections and they did fail. Motivation for therapy, why now? Especially when we meet them after a long time of marriage or being in a relationship, what motivated now? The office-based counseling, we have the PLICIT model, which is permission to ask about sexual issue that should be done first, reassurance and empathy. We give limited information for those who they have concerns, specific suggestions for certain patients when they have an issue. But intensive therapy is directed to patients who are already diagnosed when they need to be referred to psychotherapist, sex or couple therapy. Next, please. The new PLICIT is the explicit, which is the same as the PLICIT, but it allows us to have more dynamically have a feedback with every stage we go through. Another way is the algorithm. Managing sexual dysfunction can be by asking the patient about it and legitimizing the question. Limitations, when we meet limitations such as I need to consult a gynecologist or an andrologist, you need to refer. Open up for further discussions and evaluation, work together to develop the treatment plan. We here involve the patient for the best options. Next, please. Yes, next, I'm not going to talk about this. Assessments, when we do the assessment, we have several assessment methods. It's up to the clinician or the psychologist to decide which assessment is best used. But mainly we have to select something that is assessing the sexual dysfunction, such as the Arizona Sexual Experience Scale, Sexual Functioning Questionnaire. For the Middle Eastern, we have the Female Sexual Function Index that is in an Arabic language. Next, please. For vaginismus, we have the multidimensional vaginal penetration disorder questionnaire, partner version of multidimensional vaginal penetration disorder questionnaire, vaginal penetration questionnaire. Next, please. The good news is that they are self-reported, although the bad news is that they have so many questions. Next. Each of them consists of a certain. These scales are to assess the marital functioning. It's very important to assess the marital function, since psychological discomfort or interpersonal relationship problems can affect the progress of therapy. Next, please. The Sexual Dysfunctional Belief Questionnaire by Pedro Nober is a very good tool to use, especially in cultures that patients are affected by the beliefs and the myths in the culture, especially that it's related to assessing the cognitive dysfunction related to the sexual dysfunction, if it's a desire, arousal, or a vaginismus. Management plan, we have to contract with the patient about what we're going to do. They might need some sexual education. We have the cognitive behavioral therapy alone, using the dilators, mindfulness and relaxation techniques are very important. The use of medication with these patients is questionable, since we all face the problem that most of the antidepressants and anxiolytics are causing sexual dysfunction. So we have to be cautious if we need to give them antidepressants. Botox injection, physiotherapy, and psychiatric comorbidity should be dealt with by CBT or psychodynamics. In patients with sexual dysfunction in general and with vaginismus in particular, we avoid as much as we can. We have to evaluate the risk-benefit value for prescribing medications. Next, please. Possible treatments, psychosexual therapy, a type of talk therapy that aims to help in understanding and changing the patient's feelings about her body and sex. Relaxation techniques, mindfulness, breathing, and gentle touching exercises to help the patient to learn to relax. the vaginal muscles, pelvic floor exercise, such as Kegels exercise, to gain control over the vaginal muscles. Sensate focus is very important since most of these patients present with loss of intimacy. And the usual question or the usual dilemma we get in with the clients is that they are asking to fix the vaginismus problem and then they're going to have sex together. Actually, to have a penetration, they don't know that the arousal and the desire is an important component of having a penetration. So intimacy goes hand in hand with dealing with vaginismus. Next, please. Cognitive behavioral therapy is a short-term symptom-focused psychotherapy. A central objective is to break the maladaptive cognitive affective behavior. Here we have to identify the cognitive errors and restructure them because these errors has caused the behavioral activation, and we need to teach them how to solve their problems by teaching how problem-solving skills or increasing their problem-solving skills. Next, please. The aim when we do a cognitive behavioral therapy for patients with vaginismus is to focus on the pain and sexuality, to achieve pain control in sexual context, to reduce catastrophic fear of pain, to re-establish satisfying sexual functioning, to reduce muscle contraction in the pelvic floor, and to promote lubrication during sexual intercourse. Possible components in the CBT is sex education, progressive muscle relaxation, abdominal breathing, Kegel exercise, vaginal dilatation using dilators, distracting techniques, including focus on sexual imagery, rehearsing of coping self-statements, communication skills training, and cognitive restructuring, so that we can see the effect of CBT by reducing the pain during intercourse, improving sexual functioning, reducing the fear of coitus and avoidance behavior, reducing the negative penetration beliefs. Thank you. Next. Mindfulness-based approach has been understood as an awareness that emerges through paying attention on purpose in the present moment. It's like being here and now, because many patients, because of their anxiety, they are distracted and their attention span is short. They get distracted easily. So using mindfulness is a treatment program that includes education related to cognitive modeling, training in the centering the and promotion of abilities or tendencies to perceive cognition and feelings as mental events, not necessarily as reality. In addition, mindfulness may promote acceptance, compassion, and better management of ruminative and intrusive thoughts. Next, please. The use of vaginal dilators, where the patient starts sort of by herself, introduce the dilators, and she gets a timetable. It's a self-made timetable for her, so she can pain score herself with each size of the dilators, and she can see the progress, how she is improving with each size of the dilators. And the more she practices, the more the pain score drops down. The timetable, having it as a paper with her hands, gives her a look of her own performance, achieving her target, and gives her a sense of I can. It's not the initial idea that I can't, it becomes I can. Next. Pelvic floor muscle physiotherapy are very crucial for treatment of vaginismus cases. It helps them to relax and to have a better control over their pelvic floor muscles. Next. The use of Botox, which I just gonna put this slide, but I leave it to my colleagues to talk more about it since it's their area more than me. Botox injections, but to finalize my talk, I want to mention that no approach is superior to the others in allowing achievement of penetrative intercourse in vaginismus women. You have all the tools, you have all the knowledge, you have to select what is best for the patient and when to introduce to the patient. Next. Thank you.
Thank you, Dr. Reda, for this very clear presentation, highlighting the multifaceted aspect of the assessment and the management of vaginismus. So we saw the opinion of the psychiatrist, and now we are going to move on, and Dr. Nada Brahim will present us the point of view of the gynecologist concerning the management of vaginismus. Dr. Nada Brahim works in Jabr Hospital in Kuwait. She has multiple certifications from Canada and London, and she is member of the ISSM. Dr. Nada, please.
Thank you very much. Assalamu alaikum. It's a pleasure and an honor to be here. So I'm going to just dive in straight in. Next slide. Next. So I'm going to kind of like build on what Dr. Rana and Dr. Muna had already talked about. And I'm just going to briefly talk about the fear avoidance model that Dr. Rana and Dr. Muna kind of also spoke about. What I really want to highlight here is, in short, when we have a good understanding of the fear avoidance model, that can help us to really optimize our treatment approach to address fear and avoidance, which is very central to the treatment of vaginismus. And we want to kind of help our patients to embrace confrontation and deconfirmation of their maladaptive fears and anxieties. So this understanding is really central to our assessment. And as Dr. Muna already talked about, the terminology has become different, and now it's the genitopelvic pain penetration disorder. Next. Perfect. So this is the definition of vaginismus, or the current term female genital pelvic pain and penetration disorder, which Dr. Rana talked about. I want to highlight that you come to that diagnosis if the patient suffers from these symptoms for more than 6 months, causing significant distress, and that this cannot be explained by non-sexual mental disorder or a medical condition. Next. So the Lamont classification basically helps us to stratify vaginismus, and that helps to determine kind of the most suitable course of treatment for such a disease. It kind of helps us to choose the best approach for treatment, and it also kind of gives us an objective way of assessing our progress with the patient. Next. So screening for sexual dysfunction. So in gynecology environments, especially when the patient comes for assessment, usually on an annual basis, it's always good to screen for sexual dysfunction. And as Dr. Muna mentioned, we start by kind of trying to normalize conversation about sexual health, especially in our communities. We start with open-ended questions and then kind of try to focus on the 4 dimensions of sexual dysfunction, which is desire, arousal, orgasm, and pain. And we kind of tailor those questions to try to answer these aspects of sexual dysfunction. Next slide. So in our assessment, our gynae assessment, we need to have a focused clinical history taking. We, of course, ask for past medical, past surgical history, medication list, allergies, but we also try to kind of focus on things that can contribute to some of those sexual dysfunctions. Dr. Muna already talked about this, and as you can see, most of these questions are standardized. We ask them, psychiatry asks them, physiotherapy asks them, so that we can have a better understanding of what the patient has and how we can help her. Next slide. Again, so when you're taking a clinical history concerning this, always try to find a cause for that and aim to eliminate or confirm a cause for her vaginal or for her vaginismus. I usually always use the vaginal penetration cognition questionnaire, and it kind of helps the patient to kind of delve deeper into her anxiety and fears. And usually, as Dr. Muna talked about, it is self-reported. So usually the patient feels a bit more comfortable answering those questions, and it helps us to find ways to start that conversation going with the patient. And also during history taking, always try to find what motivated the patient to come right now for treatment and to seek help. And you can always use the reasons that she mentions during those history to later motivate her to continue treatment if that is what she wants, and to tailor the treatment goals based on what she wants. Next. Yeah. So this is an example of the questionnaire. Next. So again, always use the opportunity to screen for other associated symptoms that come hand in hand sometimes with vaginismus. So always ask for urinary symptoms like frequency, urgency, hesitancy, like bowel symptoms such as constipation or painful passage of stool. Because as we said, in vaginismus, what happens is that you really have a hypercontracted pelvic floor muscle. And therefore, usually you would have other associated symptoms with that, like urinary retention because the pelvic floor is really constricted, or difficulty in passage of stool because, again, those muscles are really contracted and that passage would be difficult. Again, always ask and screen for medical and psychiatric conditions. Ask for diabetes, spinal cord injury, multiple sclerosis, malignancy, that all can contribute to vaginismus. and always ask for medication and substance abuse as well. Next. Again, as mentioned really well by Dr. Muna and Dr. Rana, really delve deep into the sexual history, focus again on the 4 dimensions of the sexual function, and use that opportunity to assess and understand your patient's ideas around sexuality. What does it mean for them, their current relationship status, because that really contributes to vaginismus, and again, ask for a history of abuse or trauma. And while you're taking that conversation with your patients, aim to kind of determine the level of her anxiety and the level of her fear so you can tailor the treatment accordingly. It's really important to mention here that no matter what the patient says, you always need to have a non-judgmental manner when you're speaking to the patient. Always be empathetic, always be understanding, because you need her to open up to a conversation that sometimes is very difficult for women to have in general, let alone in our region of our world with our understanding and culture. Next slide. Physical examination. So the physical exam for patients with vaginismus is really different from the standard gynae exam. You're doing an exam for a patient who is anxious and who is fearful. And so you really need to take your time and book your appointments with that patient accordingly. So you can't do the standard 15 or 20 minutes. You really need to book an hour or an hour and a half to really kind of delve into all the aspects of vaginismus with her, and also to take your time during the physical examination. Sometimes before you actually start anything, you really need to reassure the patient that, that the examination will not be forced. If at any point she has a lot of pain or she does not want to continue the exam, that the exam will be stopped. You really need to reassure her, and you need to convince her of that. Sometimes the first visit is building rapport with the patient so that she is trusting of you, so that she opens up to you. And so sometimes I do defer some of the physical exam to the second visit. So when that relationship has been established really well with your patient. But it's really important to say that the physical exam is necessary. It is imperative, it is critical. Sometimes it's just easier to postpone it because the patient is fearful and anxious, but you really need to do it because you can find a lot of other elements that can help you to get to the correct diagnosis and to treat your patients. Usually pelvic floor physiotherapists are very, very valuable. And in some cases, I actually do invite them there for the first exam with the patient to help relax the patient and to have a full assessment done once. Because we also look at other aspects in the physical exam, such as does the patient have scoliosis? Does she have a pelvic floor issue? Does she have a pelvic ligament issue? Does she have a pelvic girdle issue? So having a pelvic physiotherapist nearby is really crucial. And then give the patient time to get ready for the physical exam. Don't rush it. Give them time to relax. Give them time to do some of the breathing exercises Dr. Muna talked about that helps to ease her fears and anxieties. Next slide. All right, so stages of the exam. So we always start with an assessment in terms of inspection. So I always start actually by giving the patient a mirror so she can see what I am doing. Again, that lessens her fear and anxiety. And it also gives me an opportunity to explain the anatomy to the patient and familiarize her with her personal anatomy. And we use that time to rule out any genital mutilation, any hymenal abnormalities. And sometimes just by inspection, because of that fear and anxiety that comes, you can actually just sometimes see contractions happening at the introitus before you even go for an exam. Now, the visual inspection of the vulva also includes using sometimes a vulvoscopy, especially if you suspect a dermatological disease as well, such as lichen sclerosis. And sometimes if you really have a hypertonic pelvic floor, you can actually see a retracted perineum because of that. Also look for posterior vestibule fissures. And then we'll proceed with a Q-tip test. So the Q-tip it's basically use a Q-tip that's wet because it decreases pain during the exam. Next slide. Next slide. Perfect. Next slide one more time. Perfect. And so when you use the Q-tip, you're basically going to press on 4 aspects. And as you can see here at the picture, you will press the Q-tip very gently at 2, 4, 6, and 8 and 10 o'clock. And you try to see if you elicit any pain. Sometimes the pain is provoked, and sometimes it's spontaneous. She just has pain without you even touching that area. And that kind of helps you to distinguish and get to the right diagnosis during your exam. Usually when you're doing a Q-tip test and you have a hypertonic pelvic floor, which can contribute to the vaginismus, you basically will have pain that really is focused on the posterior vestibule. So you'll see most of that pain or irritation at 6, 8, and 6, 8, and 4 o'clock. Next slide. Perfect. So after that is done and you do suspect vaginismus or really hypertonic pelvic floor muscle, then you can try to go on to a vaginal penetrative exam if you can. And again, that's hard and you need to really take your time in doing that. So you want to assess for the degree of vaginismus. And again, you'll use your Lamont scale. And you'll also use that opportunity to assess for infection, vaginal anomalies, adhesions, assess for muscular tonicity and pudendal neuralgia. So when you start by using, by making the patient comfortable. Start by assessing the mons pubis, mons pubis and labial folds, and just kind of go around other areas, not the area that, or the vaginal opening, so that she doesn't have excessive fear and anxiety. And so it kind of gets used to the idea of the exam itself. Again, as I said, use a pediatric speculum. And when you do use a pediatric speculum, start with touching the patient's leg with the speculum, then the mons pubis, and then slowly find your way to the vaginal opening. Again, reassure the patient if at any point she feels like she can't continue the exam, that you will stop. I usually always, if possible, also do a rectal exam to assess for the sphincter tone, because that also gives us an idea of how hypertonic the pelvic floor muscle is. Usually, if you're also suspecting other diagnoses such as pudendal neuralgia, it's easier to assess that by a rectal exam rather than a vaginal exam. And why is that? Because it's sometimes hard to get to the ischial spine when a patient has vaginismus. And also, if you have a really hypertonic pelvic floor, when you're trying to press on the ischial spine to elicit a pudendal nerve injury or neuralgia, you're also pressing on the muscle itself. And pressing on the muscle can elicit pain. And so it's sometimes difficult to distinguish between that and pudendal neuralgia. But if you do press or try to feel for the pudendal nerve rectally, then you really are pressing more on the nerve rather than on the muscle, and you can get a better understanding of your diagnosis. So the diagnosis of vaginismus physically would be the presence of a vaginal spasm or pelvic floor tension with an accompanied fear of penetration. Next slide. Okay, so sorry, can you go back one slide? Perfect, thank you. And so just to kind of go back, you're tailoring your treatment to the fear avoidance model, and can be really efficient in summarizing potential risk factors and the treatment plan for the patient. So explain to her the fear avoidance model, and then kind of use that to tailor your treatment and get to the motivation behind her seeking treatment. Thank you. Next slide. One more. Thank you. So treatment starts actually with patient education. And so ISSM and MESSM has really played a really vital part in that. Patient education is imperative. It's really important, and especially presenting accurate scientific information to the patients in a way that they can understand and can relate, and that they don't feel alone in what they are suffering through. Again, it's a multidisciplinary approach. Contributions of Dr. Rana, Dr. Muna is essential to helping patients get to their treatment goals. And as Dr. Muna already mentioned, psychotherapeutic, sex therapy intervention, cognitive couple therapy, mindfulness, relaxation techniques plays a huge, huge part, and it really is very central to being successful in terms of your treatment plan. Next slide. So as gynecology, we use every gynae assessment to educate the patient about good sexual health, so that they do feel comfortable talking about that and have a better understanding of that. And then we're going to talk about each individually, but usually in the treatment will include exposure to vaginal penetration, such as vaginal dilators, physiotherapy and biofeedback, some medication use, and sometimes surgical intervention as well. So I really, next slide, please. So before we delve more into the treatment methods, I really want to take a moment to talk about the definition of successful treatment. It's really important to take the time to really understand patient motivation for treatment. And more importantly, what is her definition of successful treatment? Because at the end of the day, you really want what's best for the patient, not what you think is best or what other people in society think is best. So that we have to have an understanding that vaginal penetrative sex does not always mean sexual satisfaction or a better relationship satisfaction. So that distinction needs to be made. There are some women who, after understanding their condition and treatment options, choose not to treat vaginismus and feel that they are happy and sexually satisfied as a couple without vaginal penetrative sex. And so that, again, needs to be respected and understood. So in terms of vaginal dilation, we're going to kind of focus on, can you go back one slide, please? So we're going to really focus on that. So then vaginal dilation is really central in vaginismus. And the idea behind vaginal dilatation is for the patient to really, again, confront and deconfirm her maladaptive fear by exposure. So when you're talking to the patient about a treatment plan, try to introduce the idea of vaginal dilatation early on so the patient has kind of time to get used to the idea. So the primary question when you talk about vaginal dilation is, what is the success rate? And we usually quote success rate between 53 to 100%, depending on the study that you're using. The next question that always comes up is, how long is this treatment method going to take? Now, there hasn't been a lot of distinct studies in the literature discussing success rate according to the patient's Lamont grade, but some studies have attempted to answer that. And one of the largest studies basically has quoted that the average treatment duration when you have a Lamont scale of grade 1 is usually 4 clinical vaginal dilation sessions. If you do have a grade 4 or more, then that usually would take up to 8 sessions or 8 clinical sessions. The next question they always ask is, what are the treatment steps? How do I do a vaginal dilatation? And I do believe that it's crucial that you do the clinical vaginal dilation in the correct manner to actually achieve success. And so you always start by using the smallest dilator that you have, and usually I say around the diameter of 1.3 centimeters. But you can, as a gynecologist or as a urogynecology, that's my background, you can also assess the levator and eye muscle for hypertonicity and then kind of use the vaginal dilator accordingly. Make sure you use a water-based lubricant. In some cases, you can also use lidocaine around 5% just to ease and decrease the pain, especially during the first vaginal dilation session where her anxiety is really high. I find that providing the patient with a mirror to see what you're doing during vaginal dilation really helps to ease her anxiety and help her to understand how to do vaginal dilatation. Now, when you do bring the vaginal dilator, first touch the patient's leg with the dilator, then the vulva, and you can rest it on the leg or the vulva for a few minutes just so that she gets used to the idea. And make sure that you talk with the patient through her fear, through her anxiety, and reassure her continuously. Then you can then use the dilator and rest it on the vaginal opening. You don't have to enter immediately and just kind of rest it there for a few minutes until she gets used to the idea of it being there. Sometimes you can see contractions, wait for them to ease, and then you can continue if the patient feels like she can continue. Do this very slowly so that she doesn't get anxious and then you fail in doing that. Once she feels comfortable, you can insert the dilator. You can only put the tip. You don't have to put the whole thing in. You can put the tip and just kind of leave it in place. Don't move it for the first several minutes. And then once she feels comfortable, you can remove it, give her the dilator and see if she can insert it on her own and encourage her throughout the process. Now, once she attains the ability to put the dilator with you in the clinic, she can do self-dilatation at home. And it's really important that you give the patient really good recommendations on how to do self-dilation at home so that it's actually successful. So always kind of advise that she inserts a dilator daily for at least 10 minutes. And then once she's comfortable with the dilation in place, then she can move it around. When she does move it around, she moves in a circular manner from 3 to 9 o'clock, really pressing on that posterior aspect of her vagina, because that's where you want to get to the pelvic floor muscles. There doesn't need to be any in and out motion at all. It's just like from 3 to 9 movement. Now, when the patient is self-dilating at home, a self-dilation diary is really crucial, and Dr. Muna kind of already alluded to that.
Dr. Nada, you have to be aware of the time. I'm sorry.
Sure.
But you have to be aware of the time. Thank you.
Thank you. Always use the dilator for a good 3 to 4 weeks. And when she gets used to it, you can go on to something that's larger and kind of go from there. Next slide, please. Perfect. In terms of medication, there's a couple that you can use. If the main issue is anxiety, then you can use short-acting benzos for acute anxiety. If it's more of a chronic anxiety issue, then you can use SNRIs. Usually when we do give SNRIs, we prefer Cymbalta over Effexor or Prestige, just because it has fewer negative sexual side effects. You can also use lidocaine, as I alluded to, a hormonal topical cream, especially if you think she has vulvovaginal atrophy, and usually start that at least 3 months prior to starting your dilatation. Again, if you suspect lichen sclerosis, start with steroid ointment a good 2 months before you start the dilatation. Sometimes if it's really hypertonic, you can give topical muscle relaxants such as diazepam or baclofen that can help really relax the muscle so you can go in with a vaginal dilator. Next slide. Physiotherapy, it's crucial, it's important. Usually we would recommend using a physiotherapist's input at least 2 times a week for a good 10-week course. You can also use body mechanics and ergonomics to strengthen other aspects such as lower limb or the back or the psoas muscle, so that can contribute to the pelvic floor being better relaxed. Next slide. Perfect. And then as we talked about Botox, Botox really was a game changer. It's a polypeptide and inhibits the binding of acetylcholine. And one of the largest studies done by PASIC kind of really showed that there was a 71% of patients after Botox experienced painless intercourse. And in 2019, a big meta-analysis came out that showed that overall Botox helped in achieving painless and satisfactory penetration. So I follow kind of Dr. Andrew Goldstein's method in terms of injecting the Botox, because he trained me. Usually I would use 100 units of Botox in a 3 ml of normal saline, and we'd give 3 injections of 1 ml each to the muscle that you feel is most contracted. And a background in urogynecology usually helps with that, so that you can identify the 3 muscles that make up the levator ani. So once the Botox is inserted, it usually disperses around 1 centimeter around the injection site. 2 weeks after insertion, then she can start the vaginal dilator or start with physiotherapy. So usually contraindications to using Botox would include allergy to albumin or Botox or even myasthenia gravis. So that also has to be taken into consideration. Possible side effects when you do use Botox would include stress incontinence. It can also include flatulent incontinence if you inject quite a bit. And in one study, they had like excessive vaginal dryness. Next slide. I wanted to kind of briefly talk about this because I keep having questions concerning that. So the role of hymenectomy in vaginismus, it doesn't really play a role other than the fact that it's a mechanical barrier that can cause pain, and that pain causes vaginismus. So just doing a hymenectomy isn't really a treatment for vaginismus itself. Next. All right, perfect. Next slide. Perfect. So take-home messages for us. So include sexual health in all gynae assessments and use that opportunity to educate on sexual health. Women should really define what a successful treatment for them is. And the treatment approach is really multidisciplinary and really focus on the management around the fear avoidance model and exposure therapy. And various treatments are available, and women with vaginismus can be helped. But they do require our empathy and our respect. Thank you.
Thank you so much, Dr. Nader, for a very comprehensive talk, including a lot of the different treatments we have and how to take care of this problem in a gynecological practice. Thank you for sharing all your knowledge.
You're welcome. Thank you.
And now it's a pleasure to introduce to you Dr. Ons Kabir, who will talk about public health awareness about vaginismus, another very important aspect. And it's a pleasure to introduce her. She's an associate professor in gynecology and obstetrics at the Faculty of Medicine in Thhis in Tunisia. And she's also a clinical sexologist. She's a general secretary of the Tunisian Society of Clinical Sexology. She is a research fellow, and she's also a member of the Middle East Society of Sexual Medicine. And just a comment, I saw there were one of the audience who asked, how can we continue talking about this very important matter? And I just want to recommend that if you're not already a member of your local society, maybe the Middle East Society, then join the society and also join ISSM, because here you will have the opportunity to interact with other people working with women with vaginismus. So welcome to you, Dr. Kabir.
Thank you so much, Anna Maria. I want to thank the ISSM and the MESSM for inviting me among this very impressive panel to talk about public health awareness about vaginismus. Next. So these are my conflicts. Next. So today I gave myself 3 educational objectives. First is to define vaginismus because people don't know what is vaginismus. If you want to raise awareness about something, first thing is to make them know what it is specifically. Then due to the changes among the DSM-5 classification, my second objective will be to classify vaginismus among other female sexual disorders. And then I will try to give a brief info about preventing vaginismus. Next, please. So what is vaginismus? So in the early 19th century, French physicians defined vaginismus as a spasm-based illness. It was defined as a recurrent or persistent involuntary spasm of the musculature of the outer third of the vagina that interferes with sexual intercourse. And this was the identical criteria found in the DSM-3 and 4. Next. But it is odd to have a definition that lasts more than 175 years. And this was not due to the testimony of validity of this definition, but it was rather a result of lack of critical attention to this disease. Next. So now we don't speak anymore about vaginismus. It doesn't exist. It is hidden within all the genitopelvic pain and penetration disorders, which is a complex term bringing together the spectrum of dyspareunia, vaginism, and other penetration difficulties. So you see that on the one hand, we have a very long-lasting definition that was very secure, and now we don't have the definition anymore, and we don't have even the word in the DSM-5. So what happened? Now vaginismus became part of the spectrum of vaginal penetration disorders associated with pelvic floor muscle dysfunction, vaginal spasm, sexual pain disorder, inability to consummate, vulvodynia, and vestibulodynia. So a number of factors motivated these changes. First, research did not support the premise that vaginal spasm was the crucial factor preventing intercourse. And while such spasm can occur in some women, they account only for about a quarter of the cases. Next, please. So we actually, what actually prevents intercourse appears to result from an intense fear of vaginal penetration or pain during vaginal penetration, or the experience of pain during previous penetration or the current one, or hypertonicity of the pelvic floor muscles. So the paradigm has shifted. And I'm really happy to talk about this after that Dr. Neda Ibrahim presented her talk, because a consideration of what typically happens during gynecological examination to diagnose vaginismus may help elucidate some of the historical confusion and current changes. So what often happens during the exam is that women exhibit much distress. They shut their legs, they turn away, and sometimes they refuse to be examined. That's why Dr. Neda said that we had to book an hour appointment for that. And gynecologists, not wishing to cause further distress or pain, they reasonably do not force an examination, and they make sometimes the diagnosis of vaginismus without ever verifying the presence of spasm. Next, please. So here, researchers did systematically videotape gynecological examinations for vaginismus and coded women's facial expressions and behaviors. And then it became apparent that vaginismic women reacted phobically in the presence of the feared stimulus, which is vaginal penetration. And that the pelvic floor hypertonicity and sometimes spasm were probably a result of the fear, just as a person with arachnophobia might tense up in the presence of a spider. Next, please. So when a gynecologist succeeded in examining a woman with vaginismus, she was often also found to have provoked vestibulodynia, which was stressed by Dr. Nada in the previous talk. The inability to experience intercourse was multimodal, as presented by Dr. Muna, and it was often diagnostically impossible to differentiate vaginismus from dyspareunia. And some women could have partial penetration, while others with time and relaxation could achieve penetration but experienced excruciating vulvar pain. So there was a spectrum of problems ranging from total inability to experience vaginal penetration to no apparent impairment in the ability to experience penetration despite pain and muscular tension. So we go back to this new entity, which is genitopelvic pain penetration disorder, with a definition that were given to you by my colleagues. Next, please. And we see that it is a recurrent circle going from vaginismus to dyspareunia to fear of pain and with the intercourse, and anxiety with or without sexual response. Next, please. So again, I'm showing you the same slides as Dr. Muna and Dr. Rana and Dr. Nada showed you, because when explaining that mechanism to patients, and we can raise awareness that it is not only a muscle problem, but it is also an anxiety problem. And that can help a lot of patients understand their illness, and also help partners and family understand what's going on with the patient. Next, please. So here I'm presenting this video. It is a documentary that have been made in Tunisia. Yeah, and it is called The Lock. It speaks about a tradition we have in Tunisia, which is called Thhis. It is a magical tradition to lock the vagina of young girls in order to create an impossibility to have vaginal penetration. So here you are seeing an elder woman doing the procedure on a young girl. And this is our reality in Tunisia. So young girls at the age of 3, 5, or 8 are called by the matriarch of the tribe. And they have to repeat 7 times an incantation, each time eating a date. And the incantation is, I am a wall, and the son of others is a string. And this is neurological manipulation, if I may say that. And then they lock the box, and the lock of the vagina is done. Then, when the girl comes of age, and because of the changes in our societies, and before the wedding night, they reverse the curse. And the elders think that it is important to have this tradition because they don't have trust in the population. So here you are seeing the curse reversed with another incantation, saying, blood of my knee, open my hole. And this is a mother showing this her personal experience with this magic tradition, and repeating it for all her girls. And this is very important because why do they do this tradition? They do it to preserve the virginity of the girls, because virginity is something very important in these societies. And
البكر بتاع البنية، شرف أبوها، شرف أخوها،
The mother is explaining that if the girl is not virgin anymore, it is damnation for all the family and for all the tribe. And if people die, damnation doesn't, and it will be a red mark on the family and on the tribe. So I wanted to show you this movie, or this short part of this movie, because I wanted to show you the importance of cultural and social impact of virginity on the vaginismus in Middle Eastern countries, and not only Middle Eastern countries. Next slide, please. So the other thing is that young girls, having been forbidden to use their vagina because of the fear of not being virgin anymore, they do not know what is the vagina per se. Next slide. And even we, as doctors, we have implemented the genitalia part of, and we have pictures of the genitalia when we talk about the representation on the brain. But when we talk about girls and women's, we have no representation of the vagina anywhere. So it is something that the scientific community have to work on too. Next. So to summarize, first, to raise awareness about vaginismus, we have to take the problem into three steps. First, we have the gynecologists and our other women's health specialists that need to have special training like the ISSM and the MESSM are doing today with a postgraduate education. Then we have to raise awareness and give this new information about the definitions and the new entities around vaginismus for the first-line healthcare professionals, either doctors, nurses, midwives, etc. And this by integrating sexual health content into the nationals and international curricular programs for their schools. And then we have to address general population. And this can be achieved especially through comprehensive sexuality education. Yes, in Tunisia, we have an embryo of that, but it is not efficient yet, and it is not generalized. And I think that it is the main campaign we have to work on for raising awareness about vaginismus and any sexual disorder, is to work on a global comprehensive sexuality education and also to adapt it for each of our countries. Next slide, please. So my take-home messages will be that vaginismus is currently part of the genitopelvic pain penetration disorder spectrum, and it is not something that we'll find in the new DSM-5. But it doesn't mean that it does not exist anymore. The other thing is that fear of pain is the common sign, not for vaginismus and not pelvic muscular spasm, because we have to shift that paradigm and use this new definition in order to be more efficient for the patients, and also to explain the illness to the patients and their families. Third is that cultural and social environment is a very important determinant of vaginismus, and that is very evident on the prevalence of vaginismus in some areas of the globe and not in others. And finally, comprehensive sexuality education programs are essential to raise awareness about vaginismus, and not only vaginismus, but also all sexual difficulties. And thank you so much. Last slide. Yes, this is a photo of my home city, Thhis. Hopefully we'll see you one day there. And thank you so much.
Thank you, Dr. Kabir. And thank you to the whole faculty for excellent presentations. And I can see we have so many questions, and we should have had a webinar of 3 hours and not 1 hour and a half. But we will We might extend the webinar a little bit if we run out of time, but I think that I will, if it's okay with you, I will start with the first question. And I think this question maybe is for you, Dr. Khaled. There's the attendee who asked, can vaginismus be genetic? You talk very much about the cultural factors and the psychological factors, but is it also genetic, or where do we think, what is the most important risk factor?
As a genetic, I don't think could. Sometimes, yes, we can say some fears are hereditary. So sometimes the cultural fears can be transmitted through generations. But at the same time, for other factor, I don't know if we can say about if the question it's about anatomical factors or what?
I think it's more about if it's something that's more biological that runs in the genes.
Biological, okay.
Yeah.
The biological factors, yes. For the biological factor, we can say we talk about infection. We talk about for sometimes abnormalities could exist. The abnormality concerning the abnormalities. Sometimes some culture do the genital mutilation. We saw, for example, in some culture, the genital mutilation is not for the clitoris only, but for the whole area. So there's deformity in the areas, so which can cause vaginismus. We can talk about also sometimes cancers, some types of cancer like vulvar cancer and vaginal cancer. They can cause also deformities in the area. Sometimes chemotherapy also taken chemotherapy for a younger girl, even if it's not the cancer, if it's not the cancer in the genital area. For example, genital cancer can prevent the growth of the canal, vaginal canal. So sometimes we can find short vaginal canal and at later age. So this short vaginal canal can cause also vaginismus for later. So this is what we can talk about biological causes. We can talk about also we can see some problem with the hymen. If the hymen is not perforated, or it's very thick, sometimes it can cause also vaginismus.
Thank you. But I think that most of you really talks into vaginismus and pain problems being something more psychological, cultural, learned, conditioned reactions. So I think a lot of the questions go into that. So if it's okay with you, Dr. Mabouli, I'll ask the next question. And there was a question for you, Dr. Mona, that says, how do you tell the couple about the time and progress of therapy in the context of their anxiety? So how do you deal with the couple? And I would also add maybe to the family. I mean, if the family is very involved, how do you talk to them? How do you explain it? How do you take into consideration that they have a lot of anxiety, are very eager that we need to solve this problem?
That's a very common question and very good one, because usually the family are the first people we have to ask them to step aside, because their pressure can sometimes violate the couple's privacy and can affect them negatively, because it's with emotional charge for each side of the marriage. The boy and the young lady's sides, they are, our daughter is good, your son is not good, and especially that we cannot know exactly what's happening during intercourse. So we try to keep the family aside. Number two is that we normalize that the problem does exist. This is how we address their anxiety, the couple's anxiety. The problem does exist and we have to deal with it, and you have to be supportive to each other during it. And I here remember that some husbands are very emotional and very caring and tender, and that does not help the female in overcoming her fear of anxiety or pain. And others are neglecting and they're not showing any interest in treatment. They also are a bad example for the how the process is going to happen. We need a husband that is empathetic but motivating the wife to work on. I usually require to see both of them, and I tell them that the time we're going to take depends on your performance in therapy. If you do the homework properly, then our time is going to be short time. If you're not going to do the homework, then it's not going to be achieved. If you don't attend your sessions, just like when Dr. Rana talked about, Dr. Neda talked about dilatation in the clinic. If the client is missing the appointments and not showing up, then the time will be long. So it's their problem to handle the issue and to deal with it in a shorter duration if they stick to the therapy. But if they don't show up and they avoid and escape, then the time will be long. Usually I tell them, let's take a trial in a month. If you are going to be persistent and you're going to be regular on your visitations, doing your homeworks at home, then we can achieve this in a month. Bear in mind that I give her time to use the dilator and the psychotherapy session. So I have to see her weekly for 1 hour.
Thank you. I think that there's a question. Oh, there's so many questions now. There's one, I think maybe this is to Dr. Nader, or maybe it's to all of you. How important is foreplay in genital pelvic pain disorders? I think this talks about pleasure. This talks about sexual pleasure, maybe. Dr. Rita?
So may I?
Yeah, please.
Yeah, so it is really important to assess pleasure in addition to pain. And as my colleague said, we have to assess when facing vaginismus, we have to assess if there is any repercussion on the desire, pleasure, excitement, etc., etc. So it is very important to know if there is a repercussion on that. And also because it is a question of fear, most of the times, we have to make the patient feel comfortable. And what can make her more comfortable than feeling pleasure? And that can really help motivate her to engage into the treatment and also seek the pleasure within the pain. So it is really important to work on that. And if there is another sexual disorder associated to vaginismus, because it cannot be the case, especially when it is a long time history of vaginismus, we have to work on that prior to working on the vaginismus per se.
Thank you. I think I have a question here for Dr.
Can I add something?
Sorry. Yeah, Dr. Mona.
Something? Foreplay is essential because it's part of getting in the mood to allow penetration. But we have to be aware that foreplay, sometimes females, the foreplay itself might reflect a sexual trauma that she did not mention, or body image discomforts. That's why she doesn't like to be touched in certain areas, or she doesn't like to be in a sexual foreplay experience with the partner. Foreplay is important during dilatation time because we are doing the dilatation over several sessions, but at the meantime, the foreplay without penetrative sex is very important to keep on the intimacy and the desire awake so that when penetration is allowed, they both combine for a good sexual experience.
So I think this talks very much into also what you all discussed, that you really need to find out what is the risk of this woman. Is it a sexual abuse? Is it bad sexual experiences? Is it fear of the pain? Or what is it that really behind this vaginismus? There's also, maybe this question asks a little bit into this, and maybe I should ask it to Dr. Nader. Do you prescribe sexual arousal, erotic books, podcasts, movies, before you do the self-penetration exercises? I mean, this is really sexological treatment. Do you tell the women to try to look for erotic material or what's pleasurable for them?
I think it's important that we approach this in a whole person manner. And if this helps to ease her into doing the vaginal dilatation, which is going to help with vaginismus, then she can go ahead and do that. So we try to treat the patient as a whole. If this helps to arouse her and to motivate her to continue treatment, so that's not a problem at all.
Oh, thank you. And I think the next question is to you too, because there are a lot of questions about how to treat this. And here we have a focus on what's pleasurable, what is the role of foreplay, what is the role of her fantasizing about what's nice. But there are several questions about different methods, and I'm trying to combine them all. And maybe it's for you, Dr. Nada, but all of you can maybe go into that. There's a question about what is the use of hypnosis? What is the use of radio frequency treatment? What is the use of electrostimulation of the muscles? And there was one more, but I'm going to find that. Hormonal treatment. So do you have any experience with these? Because I know you mentioned hormonal treatments for women that are postmenopausal, but what about premenopausal women? And what about the other concepts?
Those are really good questions. So hormonal treatment, yes, definitely plays a factor, because if she does have vulvovaginal atrophy, that will get irritated if you introduce a vaginal dilator. So hormonal treatment, a steroid treatment, if they have like in the planus or sclerosis, that definitely plays a huge part. And as I said, I usually actually start that treatment at least a good 2 to 3 months prior to starting the vaginal dilators. In terms of radio frequency, so radio frequency, what it does is that it really acts on the vaginal mucosa layer, and it also helps to increase blood flow to that area. I haven't seen a specific study looking at that, but theoretically, I don't think that it's going to contribute to the treatment of vaginismus, because you more have an issue at a muscle level, not at a vaginal mucosa level. So that's in terms of hypnosis.
What about hypnosis?
So I think Dr. Muna would also contribute to that, but I think in hypnosis, it's part of breathing exercises and relaxation techniques. And so if that helps the woman to go ahead and do the hypnotherapy, that would help to ease her fear and anxiety, I think that would be a good idea. There has been studies on some aspects of hypnosis, not great results, but there has been some results that show a positive impact.
Dr. Mo,
yes.
have any comments to that?
Yes, hypnosis has been, some few literatures discussed hypnosis as an effective treatment for vaginismus. I personally don't do it, but it's not cost effective. And these clients are really in a hurry to achieve penetration. Once they come to the clinic, I feel that there is an atomic bomb ticking in my clinic. I have to get the penetrative sex as quick as possible. Otherwise, a divorce, a family, attention will increase.
So a lot of pressure on the women. So that's really going to increase the performance anxiety, I guess. Yeah. So this is a question, I think, for Dr. Rana and Dr. Ons. Do genital female mutilation induce, or is it a risk factor for vaginismus and genital pain, taking into consideration that many families in the Middle East practice this? So you showed this movie, Dr. Ons, which was very touching for me. I think really put spot on when you see a movie like that. But what is it about female genital mutilation, vaginismus, genital pain? Can you add some comments, Dr. Rana and Dr. Ons?
So yes, the magical trick that we do in Tunisia is not a genital mutilation per se. It is a trick on the mind of little girls, and this is a very impressive cause of vaginismus here in Tunisia. So regarding the studies that have been made on women that have faced genital mutilation, pain is something that they are living with. So it depends on the level of pain, and it depends on the how did they overcome the trauma of the genital mutilation. So it depends on that. So there's no one size fits all for all these patients. Each case is a specific case, and for each case we have to do the same assessment as for other patients. So but we have to take into consideration that the examination will be very harder, and you have to overcome your own barriers and your own thoughts and beliefs when doing that. So I think it's very important, but studies show that vaginismus is more prevalent in cultures and in countries that have such mutilations. So this is a reality.
So, Dr.
Yes,
Rana?
just to add, just to add that, for example, in Lebanon, I didn't see any case with the mutilation, genital mutilation. But I saw it, for example, in some patients in Egypt and Sudan. Maybe other country also they have it, but specifically in North Africa, they do a lot of mutilation, genital mutilation. A vaginismus doesn't depend on, not always, it's depending on the degree of mutilation. Sometimes I saw patients with a very little degree of mutilation, but with vaginismus, severe vaginismus, just because of the traumatic psychological effects of this mutilation. It's a very important. It's a very important indicator for vaginismus. So it's important to assess the trauma behind the mutilation, because many times we can have good mutilation, or it's a second degree mutilation or third degree mutilation, but there is no vaginismus because there's not traumatic for the patient. She's accepting it because it's kind of cultural, within the cultural context, and she's accepting everything. And sometimes others, they cannot accept even little degree of mutilation. So that's what to add.
Thank you. Dr. Mona and Dr. Nada, do you have any comments?
I just need to add that I agree with Dr. Rana, because simply it's a ceremonial event when they do the mutilation, and they sell it to her that this is something very honorarium to the family. So this all will play with the fact that I'm doing something good. It depends on the personality traits. If she's neurotic, this experience might trigger an anxiety and fear and phobias that might be placed during intercourse and in vaginismus.
Thank you.
I just want to add one thing. I think in genital mutilation, it's not the genital mutilation itself, it's the perceived trauma because of the genital mutilation. So that's the first thing. The second thing, it can cause pain, it can cause vaginismus on how it's done. So if you've done a genital mutilation that causes pain with penetrative sex, then that will induce vaginismus. So it's all about her perceived trauma about the whole issue.
So another question here, I'm trying to combine two questions because we have so many good questions. Thank you for that. It says, thank you for good presentations. My question is, if a psychotherapist or psychiatrist can examine the genitalia, or is it better to refer the patient to the gynecologist for examination? That is one question. And the other one is, should we always refer to a gynecologist in the assessment in order to make sure that there's not an anatomical problem that might be the problem? So can the psychiatrist, the psychotherapist do the genital examination? Should we refer to a gynecologist? And should we always refer to a gynecologist? Maybe Mona and Rafa can go into that.
As a psychiatrist, I prefer to send to a gynecologist because two things. First, I'm not experienced in vaginal examination due to my area of specialty. Number two, the patient is coming to a psychiatrist, not having in mind that I will ask her for a vaginal examination or a gynecological examination. And as far as I know, only medical professionals can run a gynecological examination. Not any other member of our multidisciplinary team can do that. It has to be a medical school graduate. But personally, I don't do gynecological examination. I prefer to send to a gynecologist.
We have the same practice where I am.
Yeah, I think I want to add to that. The thing is that you are examining a patient that's already comes with anxiety and fear. So you don't want someone who, not to say who are not trained in that specific aspect to actually do an exam on a patient where they can contribute more to their either anticipated fear or actual pain that they could have during that exam. Even in gynecology itself, we do extra training in order to be qualified to treat patients like that. So we have ISSM, we have MESSM, we have other societies that help to train gynecologists to specifically treat these kind of patients so that you don't add to her trauma and to what she's going through. In terms of the gynae exam, vaginal anomalies can occur, and it is imperative that as a physician you recognize that, because it can contribute to vaginismus itself.
So what could the abnormalities be? I know you did mention someone, and Dr. Rana.
Yeah, I mean, you can have. Yeah, I mean, we talked about hymen abnormalities that can occur. You can also have vaginal septum, either transverse or vertical, that can also cause pain during penetration itself. You can have the vagina that's not actually fully developed and cannot have vaginal penetrative sex, like if you have MRKH. So there's a lot of things that can go into that. And so you do have to have some background.
So you need to make sure there's not an anatomical background. Here is another question. I don't know who wants to give a response to this. As an andrologist, what is my role towards the husband? Any guidelines? How do I talk to the husband? What do I do with the husband? Anyone who wants to comment on that?
Yeah, so I'm gonna talk. So as we have to assess sexual function among the women when they have vaginismus, we have also to look at the sexual health in the partner or in the partners, because we can have some sexual dysfunction in mirror. So for instance, we can have premature ejaculation, or erectile dysfunction that can be associated with vaginismus, and sometimes it is hidden because of the penetration problem. So this is an important thing to take into consideration in all partners of vaginismic women. The other thing, as Dr. Mona said, is the motivation. So the partner is the ally of the patient for the motivation during treatment and during therapy. And it is a very important part of this treatment, because it is a couple treatment per se, and not only the woman's work, especially if she is in a steady couple. But I think these two sides are to take into consideration.
There's also another question related to the partner. How are the partners with vaginismus affected? Maybe they don't have the sexual dysfunction themselves from the beginning, but how are the partners affected?
Here we can add, Anna Maria, that we have secondary erectile dysfunction to a vaginismus wife. And that reminds me with a case that presented to me with a male erectile dysfunction. And when we went through the history, we found that it's because of the wife having a vaginismus, but she was the first to blow the whistle to her family that he can't. So actually he can't because of her fearful response he saw in his first few attempts to penetrate. So he started to have an erectile dysfunction, and now he's coming for erectile dysfunction. Usually we see this within the beginning of assessing the case or during the therapy. So andrologist is important in this area.
Yeah, and I think that's really tells us that we really need to think about the partner, because the patient we see really carries the problem, but maybe the problem is not started with the one we see, or they carry the problem together, or it's the other one who really has the problem from the beginning. So it really talks into looking at the couple too, as you all mentioned. I think we have to conclude in a few minutes, but I think there are quite many comments about the dilators. There are comments about maybe not using the very clinical dilators, but use the silicone ones. I think maybe you can add to that, but different countries have different dilators, and sometimes you can get the ones that are colored, that look less clinical, that are a little bit nicer in the material because they are silicone. There are some comments about discussing masturbation, how to masturbate, how to stimulate the clitoris, that's very useful. We talked about sexual pleasure. I don't know if you have any comments on the concept about the dilators. We got a very nice presentation from Dr. Nada about how do you actually ask the women to use the dilators, because it's not just about putting them in and thrusting. But what do you think about the different types of dilators?
Actually, I think that a woman should use a vaginal dilator that she feels most comfortable with. As long as it's hypoallergic and you can easily clean it, then it shouldn't be any issue. If they like it in a different color or different silicone, that's also a safe dilator to use. So she should just choose what she thinks is best, as long as you can easily clean it, as I said, and that it just helps for her to keep on going with the treatment itself.
What about fingers? Because very often you also recommend that you use a finger or the partner's fingers. Do you have any comments to that in the panel?
Yeah, for sure. So you can use a finger and you can use a dilator. There has been a study that kind of compared and contrasted which is more effective, using a vaginal dilator or a finger. And in that study, they found that a vaginal dilator is a bit better than a finger. But I think the concept is that whatever she chooses to do, she continues to do it. And the whole idea is to continue with the treatment. If she feels more comfortable using a finger or using her partner or using a vaginal dilator herself, or that her partner does a vaginal dilator, it doesn't matter as long as she sticks to the treatment plan and that, again, she feels comfortable and safe doing that. Because the whole idea is to decrease her fear, decrease her anxiety so that she can continue and hopefully make a difference.
So any other comments?
In countries where dilators are not commercially exported, they can use candles because they present in different sizes. In Egypt, dilators are not present for commercial use. So it's only in clinics. Actually, they can use candles, or for those who can't afford it, they can use candles, different sizes.
So it's more about having penetrations, because it's not so important what's actually what you do the penetration with, but it's something that fits in the size and you can penetrate with. Yeah.
It's actually, sorry, I just want to say one thing. It's really good to involve the partner as well in vaginal dilatation, because it helps for him to understand the issue. It helps for them to become more intimate, and it strengthens the relationship as well. And he can also understand the angle that she finds most comfortable in a vaginal dilator, and then can emulate that when they actually do have penetrative sex as well. So it's really important to involve the partner.
Any, Dr. Ans?
Yeah, sorry, I'm seeing some comments about hand brushes and things like that. I think, so I think that we have to use something that is secure and that will not cause more harm that we are already facing. So if their dilators are not available, it's not a problem. Here in Tunisia, we don't have dilators. Patients use their fingers, they can be imaginative, but do no harm. That's the main key point.
Yeah, and it needs to be pleasurable. So it needs to be something you feel confident with. That's not, unpleasurable.
Yeah, absolutely.
I think I'm so sorry that there are many more questions that haven't been answered, but I think we have to conclude. Do you agree, Dr. Javad and Dr. Miriam? Because we are running late of time. We already exceeded the time. So I will conclude, and maybe Dr. Miriam also will say a few words, and then we'll give it to Dr. Figali. I just want to thank the faculty and all the participants. We've been more than 200 participants. That's really a lot of people for these webinars. And I think it really tells that this is a problem that's very common. It's difficult to treat. And also we have had an excellent faculty. I want to thank you. And I want to thank my co-moderator and ISSM-MESSM for arranging this. And then I'll stop talking. I just need to say one more thing. The webinar will be available online in about 48 hours. So if you go to the ISSM website, you'll see the webinar, you'll see the link, and you can just go there and you can see all the webinars we have. And then I'll give the word to Dr. Miriam and then to Dr. Vervat to conclude. Thank you so much.
Thank you, Dr. Geraldi. I want to thank Dr. Figali and the ISSM. And I would remind before we finished that awareness remains the key to lowering the prevalence of this dysfunction, and also to getting couples to consult. So thank you, Dr. Figali, for this webinar and this subject. And goodbye.
Thank you, everyone. Really, I want to thank you because it was an amazing webinar and amazing panelists, moderators. I saw all the questions and the comments. Everybody was really amazed by this webinar. And as usual, we are always supporting to do masterclass on vaginismus. in the different countries with the help and support of ISM. So we are ready for that. There is more than 800 people who registered to this webinar and more than 250 people who attended all this webinar. So I'm really surprised, and that means that we have to focus also on female sexual dysfunction, not only on male sexual dysfunction. Happy to have you, and hopefully we'll see you all during the World Meeting on Sexual Medicine in Dubai. Thank you, thank you, thank you so much.